Today, we're going to be talking about one of the mood disorders. I think most of you are pretty familiar with the terms and have heard some of the terms that go along with it, being bipolar disorder, that there's different types. It's pretty cumbersome. And I did in the homework part, that's why I really tried to put videos, especially Katie Morton's video with the whiteboard, where she kind of draws all those, the picture between type 1 and type 2. I think she does such a great job. So today I'm going to be filling in some of the gaps as well as giving you some insight on parts of videos that are in here as well as under resources on your Canvas shell. So let's just go ahead and go through this. It shouldn't take terribly long. I would say maybe 40 minutes at the most. So I would definitely, again, please, I know probably you're putting me on the fast thing where I'm talking even faster than I talk, but I will do my best to keep this concise, not because I don't want you to learn from it, but because I believe that we definitely as nurses, especially with things like this that are so, we could take this so far. And as generalists, as nurses that, of course, I want you to have a general good understanding of bipolar disorder. I will tell you, this is actually probably one of the hardest topics, at least for myself, to actually teach, because it can go so far and it's very intricate, from the brain to experiences to type 1, type 2. Now they have up to type 4. What is cyclic? What is this? What is that? So I'm going to try to keep this parallel and understanding the medications. And the questions, especially on lithium, are very common on the NCLEX questions for mental health. So as we go through, I will mention certain things, and let's just get started. So you guys took your 5-point quiz. Thank you. I will be posting, of course, this as well with the lecture. These are your notes and agenda. So you took your 5-point quiz. Thank you. I made sure that that's already graded. And we'll go ahead and do the midterm review next week in class. I prefer to do it together, just so if there's questions, we could just make sure to talk about it then. So we'll go ahead and do that. It shouldn't take too long, and we have plenty of time, because pretty much what we're doing the last until school's done is really substance use disorder, because eating disorders and personality disorders are lectures online. All right. So starting, we'll go ahead and let's just quickly go over the NCLEX rationale for the bipolar questions. And I know that some of you may skip through this part, and if you do, that is completely your prerogative, but I do think it's important. I'm not going to spend much time on this. So I would hope that you would watch it, please. So the first question is, we have a nurse who is planning for a client who has bipolar disorder and is experiencing a manic episode. Which of the following interventions should the nurse include in the plan of care? Select all that apply. Now, a couple things to look at here. What is a manic episode? We know that's definitely elevated. It's more elevated than a hypo manic state. Hypomania can definitely be easily confused with anxiety, perhaps, or ADHD, even more so in my personal opinion and in my experience, or just happiness, until you realize, oh, wow, I've been hypomanic this whole time and just thought this is how life was supposed to feel, right? So that can be a little tricky, but mania, full-blown mania, is definitely recognizable. Feeling grandiose and all those words that you probably read in your book. So I don't want to take up too much time talking about that, but it's important to understand the difference between hypomania and mania. And so here we have someone who is experiencing mania. And I will say that in my experience also, not saying that bipolar type, so mania is basically what distinguishes if it's considered type 1 or type 2. I'll say it again, but I'm going to say it now because this I found so helpful. So if somebody has a manic episode for 5 to 7 days per the DSM, boom, you automatically are type 1. Done. You have mania one time for that amount of time, you are type 1. That is according to the DSM. So for me, that is so helpful. So keep that in mind just as we're going through this. And then there's a small part that I will lecture about that piece as well. Okay, so we have this patient, and in my experience, mania is very dangerous. Remember the video we watched, Call Me Crazy? and the personality traits and all of that we saw that we'll talk more about later. So mania is actually usually, I've seen more manic patients who have bipolar disorder with bipolar type 1 be hospitalized than type 2. Not saying that can't happen, but without that kind of editing mechanism in your brain to make good decisions, you can be so dangerous to yourself or others. Okay, I know I said I wouldn't spend a lot of time on these questions, but I wanted to make sure to say that so that if you didn't listen to all of it, at least you're getting that part, because I thought it was very important. Okay, so we have our patient, and basically we're going to choose more than one answer because it asks to choose all that apply. And many people tend to get a little bit confused on number 4. And I will say this is why. Now, when they're asking the question, they're asking as far as the plan of care. So they're not saying like right now, or what are some, interventions that you think you might need to do based on their behavior. It's a very specific, like, hey, while this patient is in the hospital for the full time, what may you expect to put in their plan of care? Many questions that have to do with mania, plan of care, or some type of nutritional aspect have to do with finger foods. Why? That manic patient, that patient with mania does not want to sit and eat. They're on the move, they're on the go, they got things to do, they have 1,000 ideas going on, they have so much energy. That does not mean if you see someone pacing in the hall, they have mania though, right? So that's why number 4 counts. Many people got number 1 and number 2 right. So definitely we want to offer concise explanations. Why? Just what I said. Mania is going to cause the brain to just go a million miles per minute, if you will, or a mile, whatever the saying is. So trying to keep things short and concise, that's very therapeutic, so that we don't agitate the client. Mania, it's not all about being euphoric and happiness. It could be very quick mood dysregulations as well. So we want to keep it short. Definitely keep our limits and have healthy boundaries, because we want, not like, oh, we're the boss and you're the patient, but we want the patient to stay safe. So that's important to keep our boundaries. Of course, number 3, we don't want to do, we would never do this. We would never disregard a client's concerns. We may have a patient tell us that an alien is coming to pick them up at 5:30. We're not going to disregard that and say, no, they're not, go to your room, right? I don't think I need to say more than that. And then the last one, for this care plan, we're going to want to definitely offer finger foods for the patient as an option, because, maybe chicken tenders, or, an apple, or just something where they're getting their nutritional value, because a lot of the times eating is not happening. So 1, 2, and 4 would be the credited answer. Please let me know if you have any questions about that. Our second question is, a nurse is caring for a client who has bipolar disorder. They do not say type 1 or type 2. Note that. Which of the following is the priority nursing action? Okay. Remember how I mentioned, if they don't really give you, I never look at the answers first, but they're not giving me much information in the question. So I want to look at my answers to hopefully help guide how I can better answer this question. So I'm going to read the answers. Number 1, set no limits for the expected client behavior. Number 2, administer prescribed medications as scheduled. Number 3, provide the client with step-by-step instructions during hygiene activities. Or number 4, monitor the client for escalating behavior. Okay, so whether it's type 1, type 2, anxiety, depression, any type of diagnoses, what do we always say the NCLEX is about? It's about safety. So I don't need to know any of that, because on all of these, set no limits for expected client behavior. It's asking me which of the following is the priority. Of course, we want to set limits for expected client behavior, but escalating behavior is going to outrank that, because that has to do with safety. And then the other ones, I've had students say, well, but if they get their medication, maybe they won't get escalated. Well, maybe they're already escalated, because maybe their medication's not working. So really trying to keep it straight arrow, black and white. What is the most, as far as like safety goes here? We want to monitor the client for escalating behavior. So again, safety, safety, safety. So you can answer a question that you have no idea and you don't even know what they're asking, based upon safety. Number 3, which is our last one here, is a nurse is caring for a client who has bipolar disorder. The client states, I am very rich and I feel I must give my money to you. Which of the following responses should the nurse make? Now, first and foremost, do they say which one it is? No. Can I guess? Yeah, I would probably guess type 1 because that's a type of manic behavior. I still don't know that, but you know what? To answer this question, it doesn't matter. I don't need to. Can we accept money from a patient? No. So I know I need to, the best thing I can do as a nurse, how am I going to respond therapeutically? That's basically my job in answering this question. So I picked these 3 questions very, very deliberately, definitely the last 2, to show you that you don't always have to know exactly what's even going on to be able to answer the question, which I think helps students understand. I mean, the NCLEX we all, I think, get a little a lot anxious about. So we know we can't take the money. So what is the best thing I can say to the patient? The first one is, why do you think you feel the need to give money away? That's not a bad question. And it's kind of, I want to say, a little bit of trickery. It doesn't say that in the rationale in my book that I use, but because it is open-ended and that is assessment. So it's not a bad answer, but we never just choose one, right? Or choose off the first one. We're going to keep going. Let's see if we have anything else it's better. Number 2, I am here to provide care for you and cannot accept this from you. Now, what did we say in the first question? Very concise. We want to be consistent. We want to set boundaries, because if we take this down the rabbit hole, and especially the patient's going to be there for a while, especially if they're manic, it's not going to be a 72-hour stay. This is going to be a while. And if we don't create limits and boundaries, it's only going to actually hinder the patient. And that's not good. And we're not helping the patient heal by saying, oh my God, you're the most generous person I've ever met in my entire life. I really need the money, but I'm not allowed to take it. That's not therapeutic, actually. You're actually hurting, if anything, the relationship between you as a nurse and the patient. So, as an example. The third one, I can request that your case manager discuss appropriate charity options with you. Same thing. A lot of the time, if you have a manic patient, it comes to money, we don't even know if they have the money. Yes, the case manager could figure that out, but that's not the most important thing at this time. And at the end, I'll give you the most concise way of how I came to my conclusion of what the answer would be, which is number 2. Number 4 is, you should know that giving away your money is inappropriate. That's not therapeutic. Boom. We already know that's not right. Now, how I chose number 2, because number 1 and 3 are not bad answers. Number 4 we know is not therapeutic, so we would not pick that one. But I looked at it and I thought, because remember, I do these for myself as well, because it helps me learn too. I don't always get all these right. I mean, I don't think anyone does. So number 3. So this is basically, if you look at number 1 and number 3, they're very similar in the way of kind of guiding them to give their money away, almost, or like feeding into it, I would say is a better word, of like, oh, well, why do you feel you need to give me money? And then, oh, well, let me talk to your case manager about giving money. That has nothing to do, if we read the question, we're not addressing that. So number 2 is actually addressing what the patient is saying to me. The patient is saying to me, I'm very rich. I feel I must give my money to you. So I'm actually addressing what they're saying to me, which is, I'm providing care for you. I cannot accept this from you. So it sets the boundary between you two. Then, as I've mentioned many times, then you can ask more questions, because it probably will go on from there. It probably won't just stop and the patient will say, okay, maybe they will, or they'll say F you and walk away. Who knows what will happen? But then perhaps the second question might be, well, what makes you feel that you need to give your money away? So first is boundaries, then maybe exploring and going further and whatnot. Again, if you have any questions about that, I think that's explained pretty well. But again, I'm in my own head and I've taught these 100 times, so it might be a little different. So that is that part. Please take note that your next 15 question quiz, which is it's a take home. Oh, I think I need to set the timing up on that. I don't think I did that right. But anyway, regardless, it's I've already made it 50, the things up, the study guide. It's 15 points, half of it's bipolar, half of it's substance use. So it's like on the 26th or something, 26th and 27th. And it's take home. So please make sure that you review the NCLEX questions for both of substance use and bipolar. All right, so moving along here. So just remembering how I like to make sure to know. So just like depression is a mood disorder, so is bipolar disorder. It's a mood disorder. So studies show, and this is one that it'll show on one of the movies here. It's very short. All the movies that are linked in here are not super long. And for Nurse Mike, I really just want you to look at the lithium part. It's the one at the end. But it is absolutely just, I mean, if you really sit there and think about it, 8 years on average. And now I want to look up the study again because it may have changed, but it's in one of the movies as well. But either way, I mean, I know we're getting better, hopefully, but on average, it takes about 8 years to get the correct diagnoses for bipolar and what type of bipolar. That makes sense in a way, but it is also so sad. And I've said this in class before. What looks very similar? Anxiety, depression, and hypomania and mania. So, or what if you're depressed? So type 2, it's you must have one depressive episode for a certain amount of time. Well, many people have depression, so we could be treating someone for depression, but really they're type 1, and then we do that and we're doing the wrong treatment, and then something else happens, and I'll talk about that later. Or we think it's ADHD, then we give them that and it causes them to have flat affect. It just, main point is there are so many potential things that look like one another, which causes it to be what we call NOS, non-otherwise specified, where it doesn't fit quite in there. So treatment professionals, or those who are treating you, from my experience, tend to be pretty careful just not throwing that diagnosis around, at least those that I work with. And it's more like, let's rule out bipolar disorder. And one of the first things that we do is ask family history. Family history definitely is one of the first things I ask, and I'm not really sure why. And maybe others of you listening to this may agree. And I know we've talked about, some pretty, psychosis and schizophrenia and all sorts of things, but bipolar seems, for me at least, to have this very, very, yes, stigma to it, but very like negative content, like it's just so bad. I'm not really sure why. I mean, I don't feel that way. I would hope not. This is the love of my life, teaching mental health, but it tends to kind of, and the example I'll give is like, I've had patients that have come in and they end up having, let's just say, ADHD, but they're presenting hypomanic and they've had a depressive episode. Because myself, on a daily, I present usually hypomanic. So it could easily be potentially mistaken for that. Reason why I'm mentioning all of this is I really like the ruling it out part, but that can also take time. So just really realizing how much, I'm not saying, oh, people with bipolar disorder, we should have more compassion in this. We've looked at all of the different disorders so far, and each and every one of them comes with a set of just hardships. And again, I've said it before, feeling almost like a lab rat. Oh, you have to try this med, and then you get sick, and then you do that, and it's exhausting. So I just really want to point out that 8-year point. Now, that does not mean that has to happen, but it could. Now something here, and a lot of people don't know this, is, so let's say a patient came in and they present as depressed. They don't have bipolar history in their family. And I can't prescribe it yet, but when I can, we make mistakes, hopefully not big mistakes that are going to hurt somebody. But if someone's presenting in DSM-5 and I see it, and maybe they've been treated in the past, I don't know, with antidepressants and it was fine. I have no idea. But let's say I give somebody who has bipolar disorder. So bipolar disorder if you are diagnosed with bipolar disorder, it is contraindicated to give antidepressants. Now, I'm sure you can think, wait, I've been on them and I have bipolar disorder and I'm fine. So when we're talking about most things that I say, there's always a, exception to the rule, but I'm going to teach it the way it's done in the hospital and whatnot. I have seen patients that are bipolar and I'm looking at their medication, like, wait, what? And they're like, oh yeah, I know I've been on it for a long time. It didn't cause me to have mania or whatever. But in general, like if it was on the NCLEX or on one of my tests or something, that is how it's going to be. Antidepressants are contraindicated with someone, it doesn't matter if it's bipolar 1 or bipolar 2, because it can throw a patient into mania. And I know I just said, oh, well, if you have mania, it's type 1 automatically. It doesn't matter. That type 2 person can go above hypomania and it can go to manic. So it's really important to understand that. I always tell this quick story. I know that my Monday clinical, I already told you the story, but I'm going to share it because I think it helps you to remember. And of course, I'll keep it HIPAA quiet, if you will, so that nobody's linked to it. Patient basically was prescribed an antidepressant from a psychiatrist. Psychiatrist did nothing wrong. The patient met all criteria for depression. I'm not going to say what they went out and bought because this is on a video. If it was in class, I probably would. But went out from the time being, and usually it's about 3 to 4 weeks before you go back, unless something really wrong is happening with the medication. The patient came back and basically had spent, let's just say, I don't even know how much this purchase was, bought 2 of something that are very expensive, one for themselves and one for their significant other. And it was very clear in the mannerisms in which the psychiatrist saw the patient interacting with them that they were extremely manic, pressured speech, talking really fast, 1,000 ideas, things going on in their head. I'm acting as though, this is happening. And it was very clear, plus the purchasing and all of that. And it, in a way, it was kind of nice because boom, you just shed off like probably 7 years potentially, or however many times we have to like switch medications or do something to figure out that you have bipolar disorder, because you kind of did it by giving the antidepressant because it threw the patient into mania. Therefore, now you know for sure that they have bipolar disorder, and now you just need to figure out which one it is and go from there. Of course, we're going to take them off the antidepressant, wean them however long they've been on it. So please remember, an antidepressant can throw a bipolar patient into mania, which is dangerous. Okay. And I have that written down for you here, right here. So we talked about type 1 and type 2 when I was doing the questions for bipolar from the NCLEX questions, but in case you did not watch that part and you skipped over it, just remembering that if you are diagnosed with a manic episode for 5 to 7 days, you're automatically put into the category of type 1. Type 2 tends to be, so now type 1, it's mania, your baseline, and depression. You do not have to have you may never have depression. As long as you have had that manic episode once, you are considered bipolar type 1. And I'm keeping it very, 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 very black and white because I could make 100 like different examples, but I want to keep it very, very clear because it can get so confusing for myself included. So we have that. So just like Katie Morton drew on the board, so mania at the top, your baseline in the middle, and then depression at the bottom. Now you could be a cyclic individual patient, right? Where you go in and out and you go through a lot of mania. Some people have a manic episode maybe only once every 5 years. Some will have it much more often. It just depends. Now, with this one, with type 2, it's a little bit different. So you don't ever go into full mania. You have hypomania. So you have your baseline, and you have hypomania, and then you have depression. So you may only have depression one time, same thing as far as mania and type 1. But many people ask me, well, how do they usually present? And in my personal like observation of it, it tends to be kind of this like wave between baseline hypomania, and then a crash of depression. But when I say crash of depression, and again, this is just an example, this does not mean this is how it always looks, but where you're not hospitalized, you're at home and you just have lack of motivation, all bad things, but more toward that. And they tend to present hypomanic more so. And it's kind of almost, depending on the spectrum on where they are on their hypomania, it usually just looks like happiness. They're elevated and excited, and it's definitely not mania. You can definitely tell the difference. If I showed you two different patients, if you've not ever seen it, you can definitely tell the difference. So I don't want to say much more than that because I don't want to make it too confusing. But if you have any questions, I think the homework was definitely a good foundation, and hopefully this will kind of fill in the gaps, especially with the videos. So we talked about the behaviors with type 1 and type 2. Like with type 1, again, mania, you saw it in the movie, spending a lot of money, maybe doing risky sexual behaviors that you would normally not do, multiple partners, maybe not using protection when you would be using protection, feeling like you are just invincible and you can fly. And people unfortunately, I mean, they have, you can have a psychotic state when you're manic. You're just you are so euphoric. And I think Katie Morton said it too. Who doesn't want to feel like that? But it's dangerous, and you're not sleeping, you're not eating, you have a million projects that you're doing, and that's also exhausting on the mind too. Really think about that. I mean, it is exhausting. And then unfortunately what happens? They crash. So not crash like literally, but just internally. Hypomania is similar, just again, less elevated. All right. So what would these look like? Okay, so we talked about that as far as like conversation. It can definitely be difficult to have a conversation with someone who's manic. That's why we try to keep it concise. Even hypomania, sometimes there's a lot of maybe being tangential, which is like you can't keep focus on one thing, and it goes, and I'm sure you're all listening to this saying, okay, Miss Amanda, this is you. But that's what's so hard about mental health is personalities can very much mimic diagnoses, right? So anyway, so mania and the dangerous behaviors, I really want you to keep that link together. Okay, so treatment, this part here. All right, really, it seems, I think, harder than it is, but I got you here. So this is what I would like you to do. Number one, I would like you to watch this link here, the lithium video on how it works. It's 5 minutes, and it just tells you how it works in the brain. It's really cool. Very short, concise. I'll put it under resources as well, or it may already be there. So please watch this video. Again, you never know. It could come up like on your final, I'll say 5-minute video from or something like that. The other part is the nurse mic one. It is already, I did post it, but the only part I really want you to watch on there. So because there's 4 main medications that we use for bipolar disorder for both types, which is lithium and then 3 types of anticonvulsants. For this video here, I only want you to focus on the lithium part, and it's like the last 8 minutes of it. You can just find it. Same thing. This is already posted. And this will definitely be on quizzes and your final. It's so important. It comes up, I think, like 22 to 25% of the time on your NCLEX, because it is, I don't like to say dangerous, but you need to take it in a certain way in order to make sure that you're not going to potentially harm yourself. And we'll talk about that, meaning your body needs to be functioning in a certain way, like certain organs need to be working well, and you need to stay hydrated and all of that. So let's make some connections here. So please watch those. And now let's talk about them. So we have a mood disorder. It says take a pic of whiteboard. We didn't have a whiteboard. I just wrote down the 3 anticonvulsants. And so usually how I explain it is this. There's 2 main paths to go down: the lithium path or the anticonvulsant path. Not any anticonvulsant, 3 in particular anticonvulsants. Now on here, I did not write the other names for them. I did on the quiz though. So I will before I post it. Okay. The ones down here. So right now they're not there, but I will write valproic acid and lamotrigine, and I can't say this one. So I will write both names. However, that does not mean that if somebody's on lithium, they cannot be on one of the anticonvulsants, but it must be one of these. For whatever reason, Depakote, Lamictal, and Tegretol are the 3 that work for a mood disorder, a bipolar disorder. These are the 3. So if I asked you if gabapentin is a medication that can be used to help with bipolar disorder, technically the answer is it's no. Technically, can you give someone gabapentin that has bipolar? Yes. But if I'm asking specifically, is it a mood stabilizer? The answer would be no. Gabapentin is not a mood stabilizer. Phenobarbital, that's an anticonvulsant. Is that a mood stabilizer? No, it is not. Depakote, Lamictal, and Tegretol are all 3 anticonvulsants that are used as a mood stabilizer. And then you have lithium, which is a salt. Okay? So you can go down one route or the other, or you can do lithium with one of those 3 anticonvulsants as well. So it's okay to be on both. Just depends on the patient and how things are going. And what these medications help do with the mood stabilizers, it's a little more difficult to understand how they work, just like with certain things, we don't really always know. Lithium in the video, she talks more about how that one actually does work. And yes, it's off label if they're using the 3 anticonvulsants. That is off label. The lithium is not, that is on label. That is made for bipolar disorder. All right, so very important, very small therapeutic range. We've talked about therapeutic range. If I give you 1 milligram of Advil, that is not a therapeutic range. It is going to do nothing. This is very, very small. Now, I know some of you put 0.8 to 1.3. Again, every hospital is going to be a little bit different. We have to choose a number. This is the most common number I've ever seen in the hospitals, in any videos I've seen, anything. So we have to choose a number. 0.6 to 1.2. That is the therapeutic range. That is so small, meaning we don't want you to be under because then it's not working, but we don't want to go over because once we hit about 1.5, that's considered you're in moderate toxicity. You need to know this definitely for the first quiz, the 15-point quiz. But this is why we do so many lithium draws when we put you on lithium and we teach you certain things. So there's certain things that need to be working. So if lithium is a salt, there's a couple things we need to know. So number 1, make sure we know that it's a very small therapeutic range and we need to stay within this. So we're drawing blood like crazy, like maybe every other day when you first start getting on it. Once we get you where you need to be, unless you start showing these symptoms, like if you called me and I'm your physician, boom, you're going to the lab right now. If you're in the hospital and you are showing any of this, we usually have a stat blood draw on standby for you to go get that done to make sure that you're not starting to go into lithium toxicity, because it can cause death. Now, so we know this. Now, toxicity, it usually starts at about a 1.5. Everyone's a little bit different. Someone might show toxicity at 1.3. You never know. So that's why we never go by 100% of everything. Things can change. We want to always make sure that the labs are drawn often. Please just take a look at these different signs and symptoms, depending on if you're moderate or into severe. And now treatment, depending on the severity, what are we going to do? So dehydration is a big, big thing. So if our patient is dehydrated, so I just said lithium is a salt. So we want to make sure that we have enough hydration in our body so that the sodium does not become concentrated. So that comes down to a couple things. So let's think about our body. So if our kidneys were not maybe in the best functioning manner, do you think lithium might not be the best? That might not be the best thing for that patient to be taking. If a patient is on an anticholinergic, it dries you up. that might not be the best one to go for. You might want to go for one of the anticonvulsants, right? If your patient is on a diuretic, that might be something to look at, whether they're either going to change the medication. So this is where the critical thinking comes from, and I wrote it all down here. And it also comes down to the patient teaching, talking about diuretics. Certain medications cause you to lose fluid, right? Hydration, hydration, hydration. That's what we want to think of. Because if we are not hydrated, our sodium goes up, meaning our lithium levels can go up. The other one that I did want to say, and I don't know if, okay, so no, we don't want dehydration, no low sodium when giving lithium. We don't want our, we want everything to be even. And remember, water follows sodium. So critical thinking, which organ are we really going to want to look at? The kidneys. We just said that one. Other things to just kind of look at: food, beverages like coffee, soda, all of that, alcohol. It causes you to avoid a lot, right? What if you have gastritis or you're sick and you're vomiting a lot? These are all things we need to think of that can throw us into lithium toxicity. So this is teaching that we need to do. There's one on here I should have put, I'm pretty sure I put it here. Which is we also would, so there's something else that's contraindicated, which is, did I not put it on here? Just looking real quick. Sorry about that. What is it called? NSAIDs. NSAIDs are contraindicated because they can potentially, because they do work on the kidneys, so they can potentially cause the lithium level to become higher. Personally, I've never seen it happen, but we say no. I'm just gonna write it here right now. No NSAIDs can cause increased lithium levels. There we go. So now it's there. Okay, so I think that's pretty self-explanatory and makes sense in making the connections together on why. And those two videos that I asked you to please watch just bring it all the way together, from the stuff you've done prior to now listening to this to that. And please understand the 4 medications. And plus, hopefully you read your book. I think you'll have a really good foundation. Please, if you have any questions about this lecture, write down your questions. I'm happy to answer them in class. And we'll start substance use disorder today, Saturday. So next week, I'm going to get everything up on here. I'll put the other ones here, and I hope you're all okay. And thank you so much, everyone, just for being so kind and just everything. I'm very honored that everyone just seems so concerned, and I really appreciate that. It was not a fun day for me last Wednesday. So again, very much appreciated, and I'll say it again in class. So let me know if you need anything. I'm okay. I'm tired, but I'm okay. And I will do this now. So I hope you all have a nice weekend, and I look forward to seeing you.